You know, Hillard and his colleagues were not mistaken when they reported just as the clear fluid of the lymphatics make these vessels invisible to the naked eye, so the medical knowledge and the study of the lymphatic system has been nearly invisible. And this is exactly what happened to our next patient. Her pathology was so clear, pun intended, that we almost missed it. If you're curious, grab your chai and stick around. Okay, friends, let's hop in to the next case. Our patient today is a 13-year-old girl, previously healthy. She presented with 1 year history of intermittent chest pain, for which she visited her emergency room at her local hospital. She was presumed to have bronchial asthma, treated with steroids, nebulizers, and occasional antibiotics for chest infection. Now, one of her visits to the ER was reported as severe chest pain and as well as pleural and pericardial effusions, which prompted a PICU admission. Over there, she had a thoracocentesis and a pericardiocentesis. Unfortunately, we were not able to examine the cytology fluid from the effusions, but it was reported as negative and non-bloody. She was discharged subsequently on steroids. And now, part of her workup at her local hospital included CT of chest and abdomen. The CT chest was reported as interstitial lung disease. And mediastinal lymph node enlargement. This prompted a transbronchial biopsy, which was inconclusive and led to a wedge biopsy of the lung. The outside pathology report stated pulmonary edema, congestion, emphysematous changes with no evidence of granulomatous inflammation. So the patient was referred to us for further workup of interstitial lung disease. We reviewed her CT, chest, and abdomen at our institute. So the radiologist concluded that there is interlobar diffuse bilateral septal thickening, as well as peribronchovascular densities and ground glass opacities. They also noted mediastinal lymphadenopathy as well as abdominal and pelvic lymphadenopathy. So based on these findings, the radiological impression was either sarcoidosis because of the bronchovascular densities as well as interlobular septal thickening and collagen vascular disease and lymphoproliferative disorders. We had the opportunity also to review her wedge biopsy from the referring hospital to rule out interstitial lung disease. Now, just as many other pulmonary pathologists, I like to use the 6-pattern approach when I'm dealing with lung biopsies. So we would like to fit the pathology into a pattern, if it can be fit into a significant pattern, either acute lung injury, predominantly fibrotic, predominantly cellular, alveolar, nodules, or minimal change. So let's look at the pathology from the referring hospital. We had 3 blocks, and as we say, even though it's painful, spend at least 10 to 20 seconds at low power, and this is where you're really going to extract a lot of information before you go in with high power. So looking at all of the sections here, the pleura doesn't look fibrosed, but it is certainly widened and it is busy. The subpleural space is spared. There is no subpleural fibrosis or honeycombing. The interstitium appears to be okay, but we will take a closer look. The predominant and obvious pattern seems to be a nodular pattern, which is mostly bronchovascular, as well as there is thickening and widening of the septa. So let's look in to the histology more closer. I will start from the outside, from the pleura, and go in. Make sure that you don't miss any of the histological structures. So, for example, you can start with the pleura, interstitium, bronchovascular bundle, and then the septae. So, let's do that. Looking into the pleura, so definitely I don't see well-formed fibrosis, but it is widened and you see vascular proliferation. So at the beginning, I thought maybe this might be due to obstruction, and there is a post-obstructive dilatation. You have some secretions in the interalveolar space. And again, so there is no subpleural fibrosis or honeycombing. Let's look into the interstitium. The interstitium looks pretty good. The alveolar septae are nice and thin. The pneumocytes are behaving. The capillaries look okay. There's no neutrophils. There's no evidence of vasculitis or capillaritis. The arterioles look fine. So now let's look at, go to the obvious nodular pattern that we saw at low power, which had a predominance or prominent bronchovascular bundle at the perivascular bundle. So here you have the bronchiole and you have some thickness over here. Let's go high and see what's going on. There are spindle cells, so spindle cell proliferation, some congestion, red blood cells over here. They're surrounded by some vascular dilatation. Let's go around. So again, there is some vascular dilatation. Definitely there is congestion around the bronchioles. Let's look here. So again, there is this prominence. There is small vascular proliferation. And then again, at this area, the spindle cells. The spindle cells look bland. They are parallel to each other. They have this elongated cigar-shaped blunt nuclei, not a lot of atypia or mitosis. Let's look at another section. So the other section almost showed the same findings. Again, the pleura, the widening of the pleura and a little bit of congestion. There are some more vascular spaces underlying the pleural space, and then the spindle cell proliferation. Going into the bronchovascular area, which clearly was prominent on low power. So around the bronchioles, again, we see the spindle cell proliferation. You can observe that there are these dilated vascular spaces. Over here, again, there's a spindle cell proliferation with vascular spaces surrounded by, now definitely there are some dilated vessels with, let's look at the lining. The lining of the vessels look bland, flat, no atypia, no hyperchromasia, no pleomorphism. Let's look at another area here adjacent to these bronchovascular bundles. So here you can see there is this intraalveolar filling and there is this clear eosinophilic material. So this is along the septa now again, and you can see there is a large spaces, anastomosing vascular channels with lined with bland endothelial, or what we think is endothelial cells. And at the periphery of these anastomosing channels, you have proliferation of smaller vascular spaces. So I have some still images for you so we can really hone onto the morphological features also. We consider the lung as lobular structures. So you can imagine if you draw a line from the pleura down, you'll have the interlobular septa. So this is one septa, then this is one septa, and then this is one septa. So it squares off with a central bronchovascular bundle. And again, in this image, you see the pleura is congested and there are some dilated vascular spaces within the lobar septa over here. You have some congestion and vascular proliferation here, and then the predominant nodular appearance within the bronchovascular bundle. So you can really appreciate what the radiologist saw on the CT scan. So what they described as the diffuse bilateral interlobar septal thickening is what we see here along the lymphatic channels, and then the peribronchovascular densities and ground glass opacities are probably what we see here, with the vascular and spindle cell proliferation around the bronchovascular bundles. A closer look at the anastomosing vascular channels and the spindle cell proliferation. So the spindle cells over here, take a look, they are elongated, they are bland, cigar-shaped with blunt nuclei, no mitosis, no atypia, no necrosis, no hyaline globules are identified, at least at this power. Other areas showed this hemosiderin deposition, indicating there might be some hemorrhage, and this is what might lead to the ground glass densities in the CT of the chest. So again, the anastomosing vascular channels over here with the collagen deposition. Now, as I showed you, the interstitium was unremarkable. You can see the alveolar septa are nice and thin. The pneumocytes are bland. They're not prominent. The capillaries look fine, and the arterioles look fine. So based on these findings, some of the differential diagnoses that came to mind would be vascular proliferation, vascular neoplasm, vascular malformation. The spindle cells over here made me think of or want to rule out at least Kaposi sarcoma. Could it be a lymphangiomatosis? It's a young girl with query emphysematous changes, and the spindle cells, certainly you would like to rule out lymphangiomatosis. So CD31 and 34, which are vascular markers, proved that these are indeed vascular channels, which were quite obvious on morphology, and the spindle cells also took the stain. Another view of the dilated expanded vascular proliferation. Now this is D240, which is a lymphatic marker, and this image shows you the vascular proliferation under the pleura, which was quite significant. We saw it on H&E stain, and you can see here how the D240 just highlights your lymphatic proliferation. Here, again, this is the pleura, and you can see the lymphatic proliferation, how it is in the subpleural area along the lymphatic channels and dipping down into the lobular septae and going into and around the bronchovascular bundle. So the spindle cells now, they were positive for CD34 as well as smooth muscle actin, and some important negatives that I did not take pictures of but were negative for HHV8, HMB45, S100, and synaptophysin. This is the PR stain. So the PR stain showed focal and patchy dim positivity within the spindle cells. So in conclusion, this patient is a young girl who presented with chest pain, multiple visits to the ER with shortness of breath, mistaken to be bronchial asthma. She had episodes of pericardial and pleural effusion. The CT scan showed diffuse bilateral interlobar septal thickening, peribronchovascular densities, and ground glass opacities. The morphology showed proliferation along the lymphatic channels under the pleura, the septa, and the peribronchovascular bundle, along with spindle cell proliferation. So even though separately there was no diagnostic features, putting all these together, the most likely diagnosis considered was diffuse pulmonary lymphangiomatosis, or as it is called now, generalized lymphatic anomaly. So if it is localized, you refer to it as diffuse pulmonary lymphangiomatosis. If it's generalized, as this disease might involve the abdomen, spleen, liver, bones especially, you would call it GLA. This is a very rare disorder. It has been referred in the literature under different entities, mistaken to be hemangiomatosis, lymphangiectasia, etc. This is one of the classifications for thoracic lymphatic proliferations. So the differential diagnosis that I really considered during the workup of this case, it was lymphangiectasis, but this predominantly occurs in neonates, usually in male, and it is fatal. So most likely this is not the diagnosis. The lymphangiectasis pathologically is characterized by dilated pulmonary lymphatics, and it's dilatation of the existing lymphatics rather than increased proliferation. So next differential was lymphangioma. Lymphangiomas occur in children within 2 years of age, and the patients might present with secondary infection. They are characterized again by a benign proliferation of lymphatic channels, similar to lymphangiomatosis. However, lymphangiomas are might present as a mass, so they are common in the head and neck region or the lung, for example, but they are localized. The third differential, which was the most likely differential diagnosis in our patient, is lymphangiomatosis, and as it is predominantly in the lung, we thought that this might be a diffuse pulmonary lymphangiomatosis. It occurs in younger age group. There's no sex location. These patients have a poor prognosis, especially if they have lung involvement. And as I said, it could be localized versus generalized. We saw the pathological features are case fits perfectly within the DPL. Now, a word about the spindle cells here to differentiate it with other spindle cell proliferations. The spindle cell of smooth muscle here are parallel to each other. They are cigar-shaped, blunt edges, and smooth muscle actin positive. Now compare this to the lymphangiomatosis. This occurs in the reproductive age group, predominantly female, as you know, with underlying genetic disorders such as tuberous sclerosis. Now, lymphangiomatosis is not restricted to involve the lymphatic channels, and it will involve the lung parenchyma and the interstitium. So the dilated alveoli or the cystic spaces will be lined by the spindle cells, similar to the ones that we saw in our case. But these spindle cells will be positive for HMB45. LAM is also positive for PR. The last differential diagnosis, which is not a strong differential, but you would like to rule it out if your case has spindle cell proliferation, such as our case. As you know, it's more common in immunocompromised patient or patients who come from endemic areas for HHV8. These Kaposi sarcomas are characterized by more compact spindle cell proliferation. The vascular spaces are more smaller rather than the large anastomosing channels that we see in DPL. Of course, you know the textbook PAS positive globules, and they are HHV8 positive. So there you have it. This was a very interesting and rare case of diffuse pulmonary lymphangiomatosis. I hope you enjoyed the case. You learned something. Remember, stay curious. Bye bye, everybody.